Bismillahirrahmanirrahim. Assalamu alaikum, respected audience. Today, our topic of discussion is about corneal injury, corneal trauma in children, especially corneal lacerations. So, today's case is about a 6-year-old child who had an eye trauma by a hard object, and he had irregular lacerations, multiple over there in the eye. The vision was counting fingers, hand movements, and we received the patient over there, and we did his necessary blood works and anesthesia preparations, and to rule out any foreign body, we also did his X-ray orbits, epilateral view, and after necessary preparations covering the eye with the plastic shield, we moved this patient to our OR, where this patient was operated, and it was quite lengthy procedure, but alhamdulillah, the wound was secured, the eyeball was saved. And this is the picture today I'm showing you is after 6 weeks. You can see here how many multiple interrupted sutures were applied. It was a triangular fashion, difficult. Even there was some tissue loss, and it was difficult to manage it, but all these things were secured. And now after 6 weeks, this is the condition of the patient. You can see this patient here that the wound is closed, but now at this stage, after 6 to 7 weeks, the patient is developing cataract changes. This was the B scan, which was done very gently after the globe repair to rule out any retina damage, any retinal detachment. It was normal post-operatively. Once the globes were secured and repaired, very gently it was done, and also to rule out any inflammation or infection signs over there. So it was also done. So if we talk about corneal traumas, corneal laceration, it is fairly quite common. We encounter a number of children coming to our emergency with these problems. And usually these things should be done as early as possible. In literature, it has been documented that within 24 hours, the globe should be secured. The targets in these conditions are the two. The first target is to save the eyeball. And once the eyeball has been secured, then the physician can think about the vision. So usually in 24 hours, it depends, sometimes multiple traumas, injuries, things are delayed. Patients have other injuries, multiple. So, but even then in such circumstances, even sometimes ICU backup is not available, but within 24 hours, it should be done. Because there are high chances of infection in the eye. And as the eyeball is open, the intraocular contents are protruding out and prolapsed. So once they are out, iris like this, they get ischemic changes, they get damage, necrosis, all these things starts happening. So the timing is very critical in this. Either you are dealing with adults or you're dealing with children. They should be secured as early as possible. As I mentioned earlier, the primary objective in such situations is to restore the eye integrity and save the eyeball. This is the primary target of a surgeon. To apply the watertight sutures, to restore the normal integrity, to minimize the astigmatism and scarring. So these are the primary targets of any surgeon who is dealing with corneal laceration. If we briefly discuss about the different layers, we all know it is composed of corneal epithelium, Bowman's layer, stroma, decimus membrane, and corneal endothelium. Until lately, this thing has been further layer discovered by Professor Dua, that there is a Dua layer also situated between the stroma and decimus membrane. Stroma is basically composed of type 1 and type 5 collagen fibers. And endothelium, you know, is a single layer of cells. Main action is to work to maintain corneal transparency. Sodium potassium pumps are there. So these are the briefly different layers of the cornea. So if the corneal epithelium is damaged, usually the healing process starts within 1 hour. The limbal epithelial cells start migrating and try to cover up the wound over there, and epithelial damages, abrasions, or anything like that, superficial, they usually heal without any scarring. Although if they are not properly healing, not proper care taken off, they can lead to infections, but usually there is no scarring. But once the Bowman's layer has been violated, the laceration is so deep that the Bowman's layer has been involved, then there are very high chances of developing the scarring, which will compromise the corneal transparency. So this is a cut-off line over there. We can say that deeper to the Bowman's layer, very high chances. So once the stroma is involved, the collagen over there starts the regeneration, the healing process, fibrosis occurs over there. The collagen fibers, which are arranged parallel, now heal by fibrosis process, scarring occurs over there, and this scarring actually interferes with the vision. It makes the scar, it makes the opacity, it interferes with the vision. And the last endothelial cells, we know whenever they are damaged, they cannot be regenerated. They only replace each other by enlarging and covering the area. They do not regenerate. So this is a bit about their healing process. Many types of lacerations you can encounter: linear laceration, angled, corneoscleral, oblique, different types, with tissue loss, without tissue loss. If you are having a linear corneal laceration, better to apply first stage to bisect it 50%. And once you have done it, then you can skewer the two halves. But if you are having an angular corneal laceration, as I showed you in my first photograph, better try to stitch the apex first, so that once the apex of that triangle is stitched, then you can skewer the two lacerations, the two parts of that triangle, the apex. But if you are having a corneoscleral laceration, always we should go for the first stitch at the limbus, and after that we should move towards the cornea and then sclera. The reason behind it, that corneal should be skewered first to prevent the protrusion of intraocular contents, and after that sclera may be skewered. And it depends upon that. If sclera is involved, how long, how length, you may need also the cryo. If there is a tissue loss and you cannot apply the sutures over there, then you have to take the help of sometimes glue, sometimes you have to apply amniotic membrane, you have to use graft tissues, allografts, or tissue corneal irradiated, gamma irradiated corneas. All these are different options which can be done according to the availability. But in any case, there should be no open wound. So this is a photograph which I want your kind attention. That once after 6 weeks in the child, the wound has healed. Now it's time for rehabilitation. Usually after 6 weeks we check the wound integrity, and if it is strong enough, the sutures should be removed. The areas I have shown here in the blue circles are the entry and the exit parts of the stitch. If these entry and exit parts of the stitch show you the element of fibrosis in this shape of a whitening around it, where the wound stitch is entering and exiting, so it gives an idea to us that it is a safe time to go for suture removal. No doubt, we have to check the integrity of the main wound. We have to make sure the scarring over there, wound healing is proper. But these circles which I mentioned, and I showed you the entry and exit wounds, the whitening of the stitch over there around also gives us a clue. The second thing is, if there is any loose stitch or suture means no stitch. It is of no benefit. It is a burden to the eye. It is a source of infection. It acts as a foreign body. It entraps mucus, which is a further source of infection later on. And it can induces new vascularization over there because inflammation goes over there. So loose stitch and suture should be removed as early as possible. It is of no benefit. But when we talk about this particular case in the children, 6 weeks have passed now. So at this stage, our first target has been achieved. That was to save the eyeball. Now we have to think about the vision. And vision in these children is very important because this patient has also got cataract. And most likely, ultimately, this child will also need keratoplasty. So, if there is a loose suture, it should be removed as early as possible. Plus, we should keep an eye on new vascularization in children. The reason is, once the new vascularization develops in this cornea, even though we save the eyeball, this new vascularization will be a big problem for us when later on we will go for keratoplasty. Our grafts will be rejected. So we have to keep eye on all aspects, immediate, intermediate, and late. So that is the reason that the early removal of the sutures, provided the wound is strong and watertight and scarring has developed, we should get rid of these sutures so that we can start our other step. So at this stage, now we are planning for the cataract surgery, lens aspiration, and lens aspiration to restore his vision. And after the lens aspiration and intraocular lens insertion, we will see about the vision, and most likely this patient will need keratoplasty. I want to thank my respected audience for their attendance and attention. I hope this presentation will be beneficial in their clinical practice. Thank you.